Hey everyone, welcome to this explainer. If you're a radiation oncology resident currently in training, well, you're in the exact right spot. Today, we're locking down the critical, high-yield data you absolutely need to know for treating benign diseases. It's a really unique corner of our field, right? The stakes, the doses, and frankly, our overall clinical goals look totally different compared to our standard malignant cases. Let's dive right in. Here's a quick look at our system-based roadmap for today. We'll kick things off with the benign radiation exception, then move through musculoskeletal, dermatologic, neurologic, and cardiovascular indications before wrapping the whole thing up with some essential dosing summaries. All right, Section 1, the benign radiation exception. So treating benign conditions requires a total mindset shift. This is what we call the benign exception. Total doses? Drastically lower than what you're used to. We're focusing purely on symptom relief, functional preservation, or prophylaxis. But here is the major catch. Your precision with timing and your hyper-awareness of long-term risk management have to be absolutely dialed in. You're often treating younger patients who have a completely normal life expectancy, so minimizing that lifelong risk of a secondary malignancy is paramount. Moving right along to Section 2, musculoskeletal indications. First up is heterotopic ossification, or HO. This is that mature bone formation you see in periarticular soft tissue, usually after a major hip arthroplasty. Timing is literally everything here. You have two incredibly strict perioperative windows. You either radiate less than 24 hours pre-op, or you deliver it within 72 to 96 hours post-op. Why the rush? Because you have to intervene before mesenchymal cell differentiation happens. If you miss this window, the prophylaxis just flat out won't work. You're also going to need a way to grade this condition. Make sure to keep the Bruker classification in your back pocket. It's pretty logical. It grades severity based on how much bone has formed. You start at grade 1 with just isolated bone islands in the soft tissue. It progresses to bone spurs bridging the gap in grades 2 and 3, and then maxes out at grade 4, which is complete bony ankylosis between the proximal femur and the pelvis. So what's the dose? Well, this is a classic high-yield number you absolutely have to memorize. 7 gray in a single fraction. For HO prophylaxis, this is the gold standard, and we usually just deliver it via simple AP/PA fields. Another major musculoskeletal issue is Dupuytren's disease, which causes that progressive fibrosis of the palmar fascia. To figure out if radiation is indicated, you use the Tubiana staging system. It basically quantifies the severity by the degrees of contracture. Stage 0 is no deficit, moving to a nodule in stage N, and climbing up to stage 4, where you're looking at a severe contracture greater than 135 degrees. We typically use RT to halt that progression and get some symptomatic relief in the mild to moderate stages. Let's pivot over to Section 3, dermatologic and proliferative conditions. Let's talk keloids. These are those areas of excess scar tissue that pop up after a stressor, like a surgical incision or a bad burn. And much like heterotopic ossification, this workflow is entirely dictated by the clock. After the surgeon excises it, you've got a super tight window. You must administer the radiation within 24 to 72 hours. Wait too long, and your local control rates are going to plummet. You're going to want to burn these keloid dulcis into your memory because they definitely vary based on site and intent. Most post-excision locations get 21 gray in 3 fractions. Actually, scratch that for the earlobe. It's specifically a bit more sensitive, so we back it down slightly to 18 gray in 3 fractions. Now, if surgery is completely off the table and you're treating definitively, the dose jumps way up to 37.5 gray over 5 fractions. Then we have hidradenitis suppurativa, really painful chronic condition of the sweat glands. For this, you rely on the Hurley system. It progresses from simple abscesses in stage 1 all the way to diffuse involvement with interconnected sinus tracts in stage 3. Keep in mind, radiation is absolutely not a first-line treatment here. It's basically a salvage play for patients with stage 2 to 3 disease who've completely failed maximal medical and surgical management. Okay, moving up to Section 4, neurologic and ophthalmic indications. Pterigam. It's a benign, wing-shaped fibrovascular growth right on the cornea. Surgery alone has a really frustrating recurrence rate, so adjuvant RT is a huge help. The textbook post-op dose to remember is 8 to 10 gray, but notice how we deliver it. We use strontium-90 or yttrium-90, which are beta emitters, and you give it on a very specific schedule, day 0, 7, and 14 post-op. When you're looking at choroidal hemangiomas, your entire approach hinges on the extent of the disease. For a localized, circumscribed tumor, you can use a lower external beam dose, around 18 to 20 gray, or you can use I-125 plaques for brachytherapy. But for diffuse disease, which, by the way, is almost always associated with Sturge-Weber syndrome, you need a higher dose of 30 gray in 15 fractions using photons or protons to safely cover that whole affected area. Almost there. Section 5, Cardiovascular and Other Indications. Honestly, this is one of the coolest, most exciting emerging paradigms in our field right now, treating refractory ventricular tachycardia. When patients fail cardiac ablation, we can actually step in. The emerging standard is a hyper-precise 25 gray single fraction SBRT, and we definitely don't do it alone. The target is heavily guided by advanced electrophysiologic mapping, combined with cardiac MRI or SPECT to pinpoint the exact arrhythmogenic scar. It's just a brilliant intersection of cardiology and radiation oncology. Shifting gears to a consult you'll see all the time: gynecomastia and prostate cancer patients. Here is a massive clinical pearl. Prophylactic radiation to the breast tissue is incredibly effective at preventing pain and enlargement. But, and this is a huge but, it literally must be given before they start androgen deprivation therapy. If you radiate after they've already started ADT and the breast tissue has proliferated, the efficacy just drops off a cliff. So how do we treat it? The prophylactic dosing is incredibly straightforward. You can hit it with a single 9 gray fraction, or you can stretch it a bit to 12 to 15 gray over 3 fractions. We typically use shallow 9 to 12 MeV electrons to spare the underlying lung and heart, though tangential photons work fine too. Finally, Section 6, Essential Dosing Summaries. This quick-hit summary table is essentially your ultimate cheat sheet. It beautifully boils down every complex dosing schedule we've talked about today. The 7 gray for HO, the 21 gray for keloids, the strict timing windows, it's all right here in one high-yield reference. When you're cramming for your in-service exams, your boards, this is exactly what you want to stare at to lock those numbers into your short-term memory. As we wrap up this explainer, I want to leave you with a thought to chew on before you head back to clinic. The technical details, the fractionations, the strict timing windows, you'll memorize those. That's the easy part. But the real art of radiation oncology lies in judgment. When you have a young patient sitting across from you suffering from a painful benign condition, how do you balance their very real immediate need for relief against the invisible, lifelong risk of inducing a secondary malignancy decades down the road? Keep that question at the absolute forefront of your mind with every benign consult you see. Thanks for joining me on this explainer, and happy studying.